Hello, my name is Janet and I'm a publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision, as well as for continuing professional development. Medicine's editorial board comprises of subject matter experts across all subspecialties of clinical internal medicine. As we publish each chapter in the journal, our chairman, Albert Ferro, will be interviewing the relevant board member and chatting to them about their specialty. We hope you enjoy them. To find out more about Medicine Journal, including how to subscribe, please visit www.medicinejournal.co.uk. You can also follow us on Twitter using the handle @MedicineUK1.
Hello, my name is Albert Ferro. I'm chair of the editorial board of the Medicine Journal, and I'm delighted to be with Professor James Galloway, recently appointed professor, who works at King's with me at King's College London. Welcome, James.
Good to see you again.
Nice to see you. And the reason James is here is because he's a rheumatologist, and the November and December 2025 issues of Medicine are all to do with rheumatology. So we're going to talk about a few topics that we think are interesting and of current interest. And just to say that if anybody who's watching this wants to find out more details and wants to read about rheumatology, please do go to the issues, November and December 2025. Okay, so James, thanks for joining me. And we thought we might start off just talking about some new guidelines on DMARDs, which have been released by the British Society of Rheumatology. So tell me about these new guidelines.
Yeah, so I think probably if you look at most people's practice who are not rheumatologists, one of the most common encounters you have with rheumatic disease is not so much the new presentations, but people with established rheumatic diseases on our treatments, on drugs like methotrexate and mycophenolate, hydroxychloroquine. There's a long list of them. Every few years, the British Society for Rheumatology updates guidance on how these drugs are safely prescribed and monitored. They've just released a new update. And I wouldn't say that there aren't earth-shattering changes to what's happened, but there's some important changes which are very relevant to the generalist. Probably one of the things that has changed, though, is over the last 20 years of prescribing drugs like methotrexate, there's a growing awareness that we probably are overly cautious with how we prescribe and monitor these drugs, and that for many people, they don't need high-frequency blood tests. The risks are low, and so the guidelines, one of the things the new guidelines have done is said that for people who don't have comorbidities, for whom there's no other particular risks about toxicity, for many of the DMARDs, they are recommending that blood test monitoring can reduce in frequency down to maybe just twice a year, or even less for people who are very stable on them. And that's sort of quite a shift about making guidelines much more risk adapted around prescribing. And I think to the generalist, to the non-rheumatologist, their guidelines are quite useful in just providing reassurance that for most people on these medicines, the absolute risks are low. There's quite a few other bits in the guideline, and I think one of the other themes of the guideline is about the burden of comorbidities, which is by no means specific to rheumatology, but for example, the prescribing of drugs in the context of chronic liver disease or people with metabolic-associated liver disease, and recommendations around screening for liver complications have really been emphasized in the guidelines, along with sort of baseline screening for viral hepatitis and HIV, which are now perceived as being something that should be pretty much universally done before starting any immune modulation.
So obviously this is of general interest because rheumatological conditions are not just the preserve of rheumatologists, but they are of relevance to the general physician, especially because there are so many manifestations that are systemic.
Well, and I think that there's probably growing sort of relevance because the number of diseases we immune suppress is growing. So, for example, in earlier this year, we saw the PREDMETH trial, which was a trial of methotrexate and sarcoidosis, which compared steroids versus methotrexate for the treatment of new cases of sarcoid, showing comparable outcomes in terms of vital capacity and lung responses, but fewer adverse events, fewer episodes of new onset diabetes, and less weight gain, and less of the sort of the steroid-associated comorbidities. And I think it was published in the New England Journal of Medicine, and I think it was published in such a high-impact journal because it's signaling a game change in terms of how we manage sarcoid. And sarcoid, of course, is primarily managed by respiratory physicians who are much less familiar with drugs like methotrexate. And so these guidelines, I think, help many specialty areas, and they've been written in partnership with stakeholders from gastroenterology, neurology, from ophthalmology, from other disease areas. So hopefully they'll be valuable from sort of the network of people working in medicine beyond just rheumatology.
Indeed so, yes. And speaking of rheumatological diseases that present to the general physician, a very important one, of course, is giant cell arteritis. And that's been something where the number of treatments, the scope of treatments available has been quite limited in the past. It's pretty much been steroids and steroid-suppressing drugs. But I think there have been some important advances recently, haven't there?
Yeah, so giant cell arteritis is a disease which is, I think, often it's been neglected in the past, seeing as treated with steroids that will suffice, although when you look at the data in terms of the number of people that lose sight from it or have a stroke or an aneurysm, an aortic aneurysm, the numbers are substantial. And in addition to that, the burden of steroid toxicity, particularly in an elderly population, is substantial. So the first drug that came was this drug tocilizumab, which got its license and was commissioned and funded within NHS services in the UK, but abroad it's also come through commissioning pathways as a drug for people who fail on corticosteroids. But then we've just this year had the full results published from a JAK inhibitor trial, a drug called Upadacitinib. And so there's a lot of things about Upadacitinib that differ from tocilizumab. Both drugs with long names, both targeting quite specific parts of the immune system. Tocilizumab, people familiar with from the pandemic, an IV infusion or subcut injection you give. Upadacitinib is a tablet, and so it is a once daily tablet you can have at home. And so there's a lot of convenience around its prescribing. The trial showed clear efficacy. It met its primary endpoint, both in terms of the treatment outcome for the disease, but also in terms of meeting endpoints around steroid reduction and reducing people's need on and dependence upon corticosteroids. And also with a very sort of positive safety profile in the population they studied. Still small numbers, and I think there's going to be more data that will emerge in time to come, but it definitely feels like there's a bit of a sea change in the world of giant cell arteritis. This is not a disease which is just steroids anymore. This is a disease for which we now have 2 targeted therapy options in addition to that, and I suspect that number will grow as there's other therapeutic that are being tested in the field.
So just to clarify, upadacitinib is not yet licensed for use in this condition, is it?
Not yet. No, so it is. The trial has been published, and we expect we will hear about both sort of the licensing and funding pathways within the next 6 to 9 months.
Okay. And so in terms of treatment of giant cell arteritis at the moment, is it still very much steroids? Is that where we are clinically?
So I think we've got, for the average person who doesn't have significant risk for steroid toxicity, we would use steroids first line. And if they either fail on the steroids, so they relapse as the steroids taper, or in someone who has high risk of steroid toxicity, then we would use tocilizumab as our first option now. And I think there is the number of people being selected for tocilizumab is growing. It used to be infrequent. I think now we're adopting a lower threshold for using a targeted therapy.
And another disease that we haven't had very much in the way of treatments for is Sjögrens syndrome. Essentially, my understanding has been that up till very recently, the treatment has been eye drops and mouth lubricants and so on. Nothing in the way of very specific treatments. And again, I think that's changing, isn't it?
It is. I mean, I think it's a disease that has been falling behind in terms of rheumatic disease for which there's been treatments to come through. Not for lack of effort. And I think it's worth saying that there have been multiple trials of drugs to treat Sjögrens that have failed and that have been unable to show a benefit of treatment. And it's definitely true that we struggle with Sjögrens for a number of reasons. The disease is a chronic disease that doesn't present often acutely, and often what we're managing is the end complication of gland failure. So the glands that produce saliva and tear fail, and at that point, when you've got sort of glandular failure, it may be too late to really modify the disease. And I think some of the studies have failed, partly maybe they've recruited people who've had the disease for too long, or it's not modifiable. All the outcome measures, and you know, across the board in research, when we're designing trials, choosing the right outcome measure is so key. But I think there's been a long-held belief that targeting the B cell in Sjögren's should work. It's a disease characterized, for even people with only limited knowledge will remember Rho and La antibodies as a disease characterized by antibodies and by sort of an inflammatory infiltrate in the glandular tissue that is B cell predominant, and it is a disease in which there's a very strong association with the increased risk of B cell lymphomas. They're multomas that occur in the glands, and so there'd always been a hope that B cell modification would work. Rituximab, the B cell depleting trials have failed, but we have now seen, published in the US Congress this year, just a month or so ago, ianalumab. This is a drug that targets both the B cell and one of the B cell activating factors. So it's a dual action drug targeting B cell pathways, and is the first drug that we have seen come through in a phase 3 trial that has shown efficacy against placebo at a level that I think will now mean this drug is going to come forward and go to licensing, because it is the first time we've seen this sort of effect and in this disease area. So exciting time in the Sjögren's field.
You mentioned that it kind of previous trials have failed because, or a factor may have been that patients were treated too late, that the disease had too far advanced. Was there any suggestion in this trial that when you started treatment made a difference to outcome?
No, so the trial, I think the trial did well in recruiting people who were enriched for people with active disease, people who had modifiable disease, and I think I think there's still a question, and this is true for many of the diseases in rheumatology that we look after, is trying to separate out damage and activity in disease, and getting a trial design that includes people with activity over damage. And that is across the board. It is a little bit of a sort of black box as to how exactly you do it, because trial recruitment is always complicated, as you know. It's the people you end up recruiting to your clinical trials are sometimes quite removed from the population you were interested in when you came up with the idea of the therapy.
And of course, the rheumatological disease that is, of course, extremely important is rheumatoid arthritis. And again, there's been some important new developments in that, I believe. Yeah,
so it's been an interesting time for rheumatoid, because if you were to look at the sort of passage of time with congresses over the last few years, I think it's fair to say rheumatoid arthritis new trials have dropped off the radar a bit. There's been fewer new treatments emerging for rheumatoid, and we've got a lot of very effective treatments for rheumatoid, but then this year we've seen data published from a really interesting new class of drug, which is the PD-1 targeting drugs. These are drugs that targeting essentially immune checkpoints. Remembering that we're very familiar with these in the world of oncology, with drugs that are immune, drugs that are doing the exact opposite to the immune checkpoint. So they are immune checkpoint inhibitors, allowing your T cell pathways to switch on and kill tumors. Whereas in rheumatoid, we're giving immune checkpoint agonists, which the idea is that they would actually switch off your T cell responses to try and control autoimmune disease. Obviously, the concern there is we've got these two directly opposing treatments, one which is an effective treatment for cancer. And what would happen if you swap it? Could you potentially increase risk of cancer? And so there is a sort of a theoretical concern about targeting this pathway, and it is a drug area that has been slow to evolve. We saw peresolimab, which was the first of the PD-1 agonists went into its phase 2 trials, and we heard this year that they were stopping further development of that drug because of modest signs that the drug was effective and some concern over its safety profile, although based on small data sets. But then we've also just seen the early results from early phase trials of this new drug called rosnilimab, which looks to have a higher efficacy, a very exciting signal of response, and without so far any signal for toxicity that would be a concern around drug development. The reason it's exciting is it's a novel approach to treating rheumatoid, and it potentially is offering a disease reset opportunity. And I think the next sort of chapter in the story of how we manage rheumatoid, we're going to be more and more interested in disease interception, about drugs and targeting pathways that don't just improve the symptoms now, but potentially could, if you get maybe very early on in the disease evolution, potentially to a point where you could switch off the drive for the disease, perhaps have an immune reset, and enable drug-free, potentially sustained control. And that's the sort of the golden chalice of treating many of our rheumatic diseases. Because at the moment, if you meet a rheumatologist and they diagnose you with an autoimmune disease, you probably will get to know them quite well, because most of the time we don't have cures for our diseases. We have drugs that will abate the symptoms, but if you stop the drug, the diseases frequently recur. Whereas the golden sort of era would be if we had drugs that could intercept the disease, and then we could discharge people.
Well, these are exciting times. It sounds like it's been quite a bumper year for rheumatology trials. So very interesting areas. James, it's been a pleasure. Thank you very much once again for joining me today.
Good to speak to you.